decontaminating the whole thing and were planning to close within 3 weeks. But then something happened. Until then, we had been able to chart every single case and relate it to the first case that came to Conakry. We had like an infection chart where we could see this guy shared a hospital room with this guy who was the son of this woman, and we could trace it back. While I was in Conakry, we had a handful of suspect patients come and go, but none of them proved to be positive. So we were just planning to close. But then 2 days before I went home, another wave of patients came. And I remember thinking that now this is really out of control because we lost total overview of the infection chain and cases were seemingly popping out of nowhere. But even though I was planned to go home, I already decided there and then that I would go back. So at the end of June, I went back to Ebola, this time to Sierra Leone. A newly opened center, they said. Not so many patients right now, they said. Nothing could have prepared me for what I was going to meet. On arrival, I was informed that I would be what they called isolation medical referent, and that's basically someone who's responsible for all the medical things that go on inside an Ebola treatment center, and who has to work alongside logistics and water and sanitation people to coordinate extensions of the clinic and anything else that is needed to accommodate an increasing number of patients. When I arrived, we had 4 patients in 4 tents. A week later, we had over 30 patients and our first 2-tent extension. On the day I left, we had over 60 patients in 8 tents and planning yet another extension. This was totally out of control. Aissata, she arrived with a group of people. She arrived with her whole family. She was 20 months old, the most adorable little girl. They all had various symptoms apart from her. She had no symptoms yet. She had to be kept separate from her family if we were to protect her from getting infected. She had to basically be pried from her mother's arms. She was holding on so tight. It was a very emotional moment. The next day, the test results came back. Aissata's whole family had Ebola. Aissata was oblivious to this because she was being taken care of by Save the Children and under constant observation in case she would also develop symptoms. It wasn't until over a week later that the people from Save the Children brought Aissata back to us. She had developed a fever. We were devastated. Her test came back positive. But what were we to do now? In the week since they all arrived, her whole family had died. Every single one. She was 20 months old and she was alone in the world. The people from Save the Children had earlier tried to trace any existing members of her family to place her with, but they came up empty-handed. She was, in fact, alone in the world, and she had Ebola. We had to think outside the box, which basically brought us to the idea of the box. We basically constructed a high-walled crib out of the box that our generator came in. We lined it with a blanket, put a bunch of teddy bears inside, and that's where she had to stay when we were not inside. We couldn't risk her running around, going out of the center. We couldn't physically be in there at all times to take care of her. So Aissata had to stay in the box. Her first days, she was really sick. We tried to comfort her, but I guess we weren't really comforting in our yellow plastic suits. She wanted nothing to do with us, but we all became very attached to her. Even the cleaning guys, they would go and check on her every time they went inside the isolation. Gradually, she started feeling a little better. She started appreciating the times we took her out of the crib, allowed her to walk around, when we fed her outside of her box. But she was a little mischievous one. One day, she had been complaining and a fellow patient had felt sorry for her and taking her out of the box. But then that fellow patient didn't watch her after that. She ran towards us to where our low-risk area was, where we were dressed in our normal scrub suits. She knew us by then, and she wanted to come and stay with us. The sight of 30 grown-ups scared of a little toddler running around on her unstable feet was quite amusing, but it was very sad at the same time. Nobody was able to pick her up, and everybody backed away as she approached. One of our doctors managed to quickly put on his spacesuit to pick her up and bring her back inside the isolation. The cleaners started spraying the ground she had walked on with chlorine. The thought of a toddler being something this dangerous and terrifying was absurd. Aysata stayed with us a long time. Then, almost 3 weeks after her admission, her tests returned negative. Aysata had made it. She had fought the fight against Ebola, and she had won. It was a mix of happy and sad feelings that came up. Of course, we were glad that she had made it, but where to now? She was all alone in the world. People are reluctant to take in children that have any connection to Ebola. There is a fear in the community of anything Ebola related, and probably most of these fears are understandable. But for Aysata, these fears could be devastating. In the end, one of our nurses decided to take her in, and until this day, Aysata is living with her. But what about all the other children? There are orphans too many to count in the 3 countries. Children who have or have not had Ebola themselves, but have lost 1 or 2 parents or their whole family to the disease. We saw countless examples in Sierra Leone. There was no proper system in place to take care of these children. Each case was dealt with separately. In some cases, we found distant relatives that were able and willing to take the children in. Others went to live with Save the Children or other organizations, and then it was on them to find a solution. The case was out of our hands because MSF usually doesn't deal with these kind of issues, and we always try to find someone appropriate to take care of them. Then there's another problem with this outbreak, apart from it being an outbreak. It's healthcare. And I'm not talking about Ebola screening and treatment, although that is an issue in itself, but all other forms of healthcare. A lot of healthcare facilities have simply closed their doors. Some have lost all their staff to Ebola. Others don't want to or can't deal with the added infection control measures needed to keep their staff safe from the disease. Referral hospitals are few and far apart, and almost no surgeries are being performed in the 3 countries right now. Anybody with symptoms fitting with the description of Ebola, and we saw earlier that they're very vague and could be a lot of other diseases. All of them are admitted to suspect areas of treatment centers where they're at risk of contracting Ebola from the next patient. Or basically dying of whatever disease got them in there in the first place before it's properly diagnosed. We have children dying from simple diarrhea and from pneumonia at an even higher rate than before. The big 5, you probably heard of the big 5 killers of children under 5. They're even more ruthless right now. Women are dying in childbirth because they can't get the emergency help that they need. The healthcare system has shut down. So Ebola-related deaths are not just the deaths of those who have contracted the disease. The virus is killing a lot of other people as well. I stayed a total of 5 weeks in Sierra Leone, at the end of which I was exhausted. Not physically, but I was exhausted psychologically. For a healthcare worker, it's devastating to work under the conditions where you know that no matter what you do for your patients, 70 to 80% of them are going to die, no matter what. Of course, this percentage, this 70%, the poster before said 1 out of 2. The WHO today said 70%. It's a little variable from place to place, and this varies, or it mostly depends on the culture and beliefs in the area where you're kind of talking about. In Conakry, in a capital with good information systems and relatively educated people, the patients came in earlier and managed to receive care early on in the stages of their disease. There, our mortality rate was around 50 to 60%. In Calhoun in Sierra Leone, a rural area consisting of many small villages, spread wide and far with a low school attendance rate and little or no communication systems, Rumors were easily formed and spread, misbeliefs were long-lived, and people came late or never to the hospital. Those who did come were most often so far progressed with the virus that their life was not to be saved. This had absolutely nothing to do with what I did for the patient. People either lived or they died. That's how it looked like to me. You could have somebody looking absolutely fine in the evening and dead in the morning. This is extremely difficult for any healthcare worker. We are used to being able to impact the progress of a disease, to slow it down, treat it, or manage it in some way. Ebola seems to have a mind of its own. After repeated calls from MSF and others, countries like the US, UK, France, China, and Cuba have started committing assets and personnel to the affected region. The United Nations Mission for Ebola Emergency Response, it's a new mission by the UN, UNMIR, has been set up and will be based in Ghana to pursue 5 strategic priorities: to stop the spread of the disease, to treat the infected, ensure essential services, preserve stability, and to prevent the spread of the disease to countries currently unaffected. MSF teams in West Africa are still seeing critical gaps in all aspects of the response, including medical care, training of health staff, infection control, contact tracing, epidemiological surveillance, alert and referral systems, community education, and mobilization. This is why the message that MSF has been stressing now, and has for a long time, is that we need more people on the ground now. We need effective coordination of the operation, both of medical case management as well as appropriate dead body management, effective contact tracing, and active case finding. This has been lacking up until now. But more is needed to stop the epidemic. The world needs to put in action the search and development of a vaccine that can be available for the whole region. The normal procedures need to be bypassed or bent in some ways with an open source, massive resources, and political backup. We need to show flexibility in the licensing process and the normal trials within reasonable limits to be able to provide vaccinations for this virus as soon as humanly possible. This will require innovation, it will require political bravery, and huge amounts of money. This will still take a lot of time, and this is why we need to work on both aspects simultaneously should we want to stop the epidemic. Thank you.
So again, thank you very much. We are going to wander around with microphones, and so we're going to open up the floor for any questions. So would you like to come to the table? Sure. Excellent. Yeah, so if you have any questions for the speakers, now would be the time to ask. No one at all. No one going to be brave.
How long is the infection still able to spread post-mortem? So what's the protocol with that with the bodies after they've died? I don't know if you've had any, I'm sure you've had experience with that.
Yeah. Basically, at the time of death is when the virus load in the body is the highest. So post-mortem body is extremely infectious. So the procedures that need to be put in place is that the body needs to be disinfected. It needs to go in a body bag that then is again disinfected and buried as soon as possible in a grave that's even deeper than a normal. I don't remember 2 meters. I'm not sure about the exact depth, but as soon as possible.
Definitely more mics.
Hello, this is Anthony Doctor on my right, and I would just like to ask, who do you suspect is the intermediary host?
I think it's monkeys and non-human primates and other bushmeats, because I think there has to be an amplification. looked at bats, they do find some virus, they do find some evidence, but there just isn't enough of it to be a threat unless people were actively eating fruit bats. And I think that does happen in some communities, but you tend not to butcher them first, just throw them on fire. So I would say monkeys, non-human primates, and perhaps deer, if they can be affected.
Yeah, this question is also for the doctor on the right. You were talking earlier about how you couldn't get funding for a vaccination or something like that if the vaccination wasn't currently an issue. Do you think there's any way that that could change? Or?
Oh, that has changed big time. WHO suddenly sat up, and they now have got fast forward implementation of these vaccines that have been sitting in lab freezers for goodness knows how long. It's just the political and financial will wasn't there to fund vaccine development for something that couldn't make money. Because this is going to be for the better of humanity. There's no money to be made out of this vaccine. And so for me, that's a really positive step forward for all diseases, and maybe we could take money out of medicine, and that would be great. So we support financially, but we don't make money from it, not for profit.
Thank you for the talk from both of you. I have a question for Hilde. I'm
Yes.
sorry.
Pretty good, thank you.
I have a question. What is the situation of post-mortem treatment of the bodies on the ground? I mean, I know that contamination afterwards is extremely dangerous, but how are things afterwards? Thank you.
It varies between the three countries, but usually it has been the local Red Cross that have been dealing with dead body management and active case finding. And when we talk about active case finding, that's also dealing with dead bodies. They either come to villages and find deceased and are able to deal with it right away. But like I said in my talk, for example, in that little town, 28 people had died, and the people had dealt with it by themselves before notifying anyone else. So it is lacking big time, but great effort is being put into that right now, scaling up the response and the active dead body management.
Any other questions?
Hi. 1.5 questions just. Do you think there's a lack of competence or willpower in the governments in West Africa regarding how they tackle the Ebola infection? And in addition to that, should be the commercial flights been shut down earlier, or because they're still open at the moment? What's your opinion on that? Thank you.
Lack of competency, well, I don't want to bash anyone, but we have to look at the fact that these three countries are among the poorest in the world, and their health system was already at breaking point with all the things they were dealing with to start with. So they did not have the capacity to deal with this kind of outbreak, not at all. Regarding commercial flights, I don't really think that shutting them down would help us at all. I don't really see the profit in doing that, and I don't think we should be. I don't know how we would tackle that, but both people that are aid workers need to get to the places to actually be able to provide help, and also flights with what do you call it? With drugs and supplies need to be able to go in as well, so we cannot.
Yes, but there's a difference between commercial flights.
True.
And
Yeah.
private flights, because I think the WHO has different.
Well, WHO has their own international flights, whereas MSF does not. So we use commercial flights to get there. So yeah.
Are there any other questions?
for the talk. So how would you say that countries like Senegal, where the outbreak is not, like for the moment it's contained, how can they keep it that way and stop there being an outbreak that's not as big as that?
Well, basically, anybody working in healthcare needs to be informed about the risk of Ebola, and they need to be able to identify the risk factors for people who are coming into healthcare facilities. The general public also needs to be informed, to be on the lookout, and they need to have systems for being able to notify health facilities if they think that there's a case somewhere.
Could I add to that? Senegal is much better organized and much more wealthy with better infrastructure than the three countries that are most affected. And it's really poverty and war and lack of organization and lack of political international will, I think, that has played a big part in it.
Are there any further questions?
Yeah, first of all, thank you for the very interesting talks to both of you. So what do, again, both of you say about the current media hysteria that we experience? So, I mean, 200,000 people die from flu every year. We've got about, I think, 25 to 30,000 deaths from dengue fever. So that's also very bad diseases, but they're not causing that much panic, especially among people in Western countries. And from what I read in newspapers from all around the world, is people are just keep these people out of our countries, don't let them in, don't get them to our healthcare system, don't let them infect our people. While we obviously need more help from the Western countries at the moment.
Okay, so I should say I work on malaria. Malaria kills 1,500 children every day. So we haven't hit that target yet with Ebola. I haven't watched the media, the popular media on Ebola for a purpose, because I didn't want to be frightened, and I don't agree with the way information is handled and delivered to the population at large. And so that's why I went to the learned journals that have some kind of control over what's published. The fear, so I was saying to someone that there's a very senior consultant in infectious diseases in the medical faculty here, and last week he told me, oh, but the virus has changed. This is a new outbreak. And I said, well, I don't think it has. I think the problem is that we didn't contain it very quickly, and I still would love to know why we didn't have the might of the international community in countries that we know are so poor earlier on, like in March. And so, so the hype and the fear, yeah, I don't want to sit beside somebody on a plane that I think is coming down with SARS. I was in Southeast Asia for that. Nobody does. But you sit there and you're generous and you think, this is really crazy to be afraid. To start saying we don't want these people in our hospitals, actually in our hospitals it's not such a huge problem. We do infection control very well. And so I don't know what you do about it. It's already started. There's such awful hype around, and if a senior consultant in infectious diseases can come out with that, I'm not really sure what we do. Actually.
Just to add, the media hype wasn't there when I was in Guinea in May. My dad, when I asked my dad if he was afraid that I was going, he said, well, you might as well get hit by a bus somewhere. It's not like that dangerous. But then when I got back from Sierra Leone, my mom called me every single day to see if I had taken my temperature. So it just creates this mass hysteria that has been, seems to just develop from the fact that now the Western countries feel like they are threatened in a way, that there's a risk of it coming. They haven't been threatened by malaria, it just stays down there. So it hasn't been a direct threat to them. So now media hysteria is, I'm not very happy about it because it doesn't seem to produce anything other than countries basically covering their own behind, not actually going into action and stopping it where it originally came from. That's what needs to be done. We know infection control in the Western countries. We don't need any particular extra resources to be able to deal with a case of Ebola or two. But what needs to be done is to stop it in West Africa.
Hi, what do you think needs to be done to dispel the distrust that many people have of the healthcare facilities and services that are in place that prevent them from bringing in their family members sooner or at all?
If I had the magic solution, I'd tell you, and probably would have told a lot of other people. What seems to be the main reason for it is because the communication and information systems are not that strong in these countries, coming back to lack of infrastructure, poor countries, low education. So basically what people know is somebody brought my uncle there and he never came back, because they just get buried as soon as possible and they never see them again. So that's how a lot of rumors are spread, and they spread really fast. It's quite amazing. So I think it's not only about information, but it's about transforming information into knowledge. And that's what seems to be, because there's a lot of information out there and people are going around informing, but how to get that into actually transforming to knowledge is something I would like to know. He has been holding up his hand for a very long time.
Thank you. Thank you so much. To touch on a point that you made earlier, Dr. Coxing, there was news out this morning that, what's his face? Mark Zuckerberg, founder of Facebook, pledged $25 million to whoever would find the cure for Ebola. So you said that you wanted to take the money out of medicine, but do you think that that kind of a pledge should be encouraged from entrepreneurs and philanthropists in order to get the cure out, or to at least spur the innovation from researchers?
I think at the moment, the money really has to go on the ground. I mean, we need it today, you need it today, you needed it in March. The likes of Mark Zuckerberg pledging 25 million, well that's 25 million not for profit. We need money in medicine, don't get me wrong. What we don't need is people making profit out of medicine. So yes, any donation. I'm not sure whether putting 25 million into a cure might be the best spent money just at this point in time, but it would be nice if there was a vaccine, because this virus is in the local animal population. It will come out from time to time. It would be really lovely, but don't forget what Gunnar said. Actually, Ebola is not the biggest health concern in these countries. And so, but yeah, I wish more people who are wealthy would actually turn a lot of their money back into health for people, for the good of mankind. And that would be nice.
Just one more question. So this other question kind of touches on an article that I read about how the Catholic Church has more dispensaries and also more trust in the local communities in terms of dispensing vaccines, cures, and even working on containment. How can the Red Cross or MSF, other NGOs, how can they implement the same strategies that the Church has so they gain as much influence in the region as the Church?
Honestly, I never saw the Catholic Church in either one of the countries that I was working in, so I can't really comment on that. I wasn't aware of this.
I was just wondering, why do you think it took so long for the international powers to get behind the issue of Ebola and acting it? Do you have any thoughts?
Well, so historically, since 1976, you had an index, you had 3 or 4 months, you had an outbreak notice, and you had people in there to contain it. Honestly, 111 cases in March this year should have been contained. I can't think why. And I think now maybe we have to have some special strategies in place, because Uganda can control, Senegal can control, Nigeria can control. They're all well structured, they have a process in place, they understand control. If you live in a very poor country, actually there's nothing going for you. So maybe what the international community should do now is keep a watch over the poorest countries, and when they have some kind of outbreak or crisis or something, particularly health crisis, maybe have something special in place to help them very quickly, provided that their governments want it. Because don't forget, you have to be really invited in, you can't just plow yourself in. But it seems that, it just seems so sad. I can't believe it. Yeah.
And just to add, in the past, since 1976, we've had, I think I'm not wrong, 23 outbreaks of Ebola that have been varying in sizes, but most of them have been quite small and either self-contained or needed minimal intervention or medium intervention to be able to stop them. I just don't think that people were kind of prepared for the massive impact it would have to have the outbreak start in an area like it did this time, in a border area where the cultural practices are kind of similar across the borders and people move back and forth. And there we are dealing with 3 ministries of health and 3 different approaches to outbreak control. And then you have pride of countries that are not willing to declare an outbreak in their country. I mean, Sierra Leone was 2 months later in declaring an outbreak, although it was quite apparent that there were already cases in Sierra Leone around the same time as they were starting in Guinea and Liberia. But they denied having any cases of Ebola until I think late July, I want to say. So it's kind of 3 different ministries of health that you're dealing with. You have the borders, you have a lot of things that are hindering you in providing proper outbreak control.
You were saying as well how the symptoms are so vague and could be lots of other conditions. What's the awareness in local communities of Ebola, and how well do they know to go and get help and to get to secondary healthcare centres?
Well, that comes back to information transforming to knowledge, and I think up until now, it has been imprinted in people. You have diarrhea, you have vomiting, you drink water and ORS and you'll be fine. If you have fever, you have malaria, you start malaria medication. And this is knowledge. This is what people know and know what to do. So basically when somebody was coming and saying, if you get diarrhea, you get vomiting and you get a fever, you might have Ebola. They're like, no. I've been told that it's probably malaria or gastroenteritis. And they stick to what they know. And it has been difficult to kind of introduce a new disease. We have to remember it's the first time West Africa has had Ebola. The other outbreaks were all in the central region, and it has never been in West Africa before. It's a disease that people don't know, and usually people are afraid of what they don't know. So
one thing that the money, the 25,000 or million or whatever it was, could go to is a rapid diagnostic test, because we know the antigen, we know we can make antibodies to it, and so a rapid diagnostic test should be very easy to produce very quickly, that can go to villages, but again it would have to be supplied by the international community because they can be a bit expensive, but that would be, I think, quite easy to roll out very quickly, and then you would break down this diagnosis or this misconception, and then people with other diseases wouldn't be put next to cases of Ebola, and people with Ebola would get the rapid treatment that they need.
it would be fantastic.
Yeah.
And already fake rapid diagnostic tests are on the market in these countries. So that's a big concern.
Yeah. But that's actually very, very possible with what they know right now.
Okay.
So just a question for Dr. Coxon. You said your friend Nathan or something was predicting outbreaks. Did he predict this one, and has he predicted anything for the near future?
No, he's actually called a virus hunter. He predicts things that haven't yet caused problems. And so they have sentinel sites and they work with people who hunt and who eat bushmeat. And they actually screen the hunters and they screen the bushmeat. And then they have what they call, they've a lot of noise, background noise, and then every so often they pick up something. But so far they'll never know if they've prevented an epidemic, because if you prevented something you don't know. But he's very good, you should look him up, TED Talks and things.
I think we've got time for about 2 more questions, so if there are questions on the floor.
Yeah, thank you both so much for your speeches. Obviously, I appreciate neither of you have a crystal ball, but given the current global response that's happening at the moment, and things that's going to change in terms of the global response to Ebola, to what extent do you each personally think that the virus is going to continue to spread? Do you think things are going to improve now, or do you think it's going to get quite a lot worse still to come?
I think it's going to get a lot worse before it's going to get better. The response has been very slow, and if we focus on only vaccines or medication right now, that is obviously going to take a long time, and it grows exponentially. Each patient can usually, or does usually, on average, infect 2 other people. So this week we have 10, and next we have 20, and then we have 40. So it grows really, really fast. So before we can even imagine having vaccines or medications rolled out on such a big scale, it's going to get worse before it's going to get better. The response by the UK sending military troops is great, but we need a lot more. Currently we have around 650, I think, beds in the 3 countries, treatment facility beds. We would probably need around at least 6,000. So the need for response is so huge that it's definitely going to get worse before it's going to get better. So I think we're probably looking well into 2015, late 2015, before we'll see any kind of end to this.
So I think if we can properly protect the surrounding countries in some way, take our efforts to another level now. We've actually missed the boat with this tracing contacts, containment and all of that. We've missed that particular boat. I'm very optimistic, and I think now that the agencies have sat up and taken notice, but I think we probably can devise new methods to contain, and it may not get back to the ones that worked formerly in smaller outbreaks, but an awful lot of people need to be engaged, and it will cost a huge amount of money. And apparently in this economic global downturn, or whatever you call it, that was one of the reasons that I read, is why this outbreak was not given the money that it needed. And so I think now that we're all sitting up and taking notice, I think it can be contained, but I think we're going to need a brand new strategy, like a huger strategy, and I think if they can roll out diagnostic tests very quickly, it will protect people who are sick and don't have Ebola, and that's a big thing. And so, yeah, no, I don't know. I hope the numbers start to go down very quickly. I don't know. They'll take a huge effort.
Just to add some context to the huge effort, the most recent MSF approximation for how much money it's going to cost them to contain the cases we have right now, not including cases that are going to come, is they need $1 billion. And that number jumped from 10 million to 1 billion in the space of 6 days. So that's just a little bit of context to how much of a problem we're creating by not quite containing this yet. So, James, do you still have a question?
Thank you very much for the presentation. You mentioned about rumours spreading in the local communities, and just out of interest, from the point of view of health belief and health perception, how do local community and local population perceive this outbreak?
Like I was saying, they see their relatives go to the centers and never come back. So a lot of different stories came up. For example, that we were doing organ harvesting and selling their organs. I was asked by a local news reporter how much blood we take from each patient, and I told him it's a tiny little test tube, 2 milliliters, 3. And he's like, well, because the rumor is that you're taking a